between 2 to 5% among adult men and post-menopausal women in the developed world is a common cause of referrals to gastroenterologists, between 4 and 13% of referrals. When referring to new iron deficiency anemia service at Barnsley, these are what we wanted to identify: low haemoglobin, low ferritin, microcytosis and hyperchromia, and TTG to screen for celiac disease. And we do a urine dipstick when patients come and see us in the clinic.
I get the boring part about numbers. So one of the things that we're looking at from the hospital's point of view is reducing non-elective spells as a result of iron deficiency anemia. As you can see, it's a very crude graph, but in 12-13 we had 87 non-elective spells, which went up quite markedly in 13-14. And then in 14-15 still rising, but not as quickly. The cost to the hospital and the CCG as a result of that is, as we can see, the non-elective spells are going up, and it's the non-elective spells.
Sorry, can I just ask what a non-elective spell is?
Like an emergency admission.
Thank you very much.
As a result of iron deficiency anemia, and that's as the primary diagnosis. So we've seen almost a 50% rise in non-elective spells over that 2-year period. Non-elective spells cost 3 times as much to treat as elective spells, and day cases as well. So the primary aim that we're trying to get through this iron deficiency anemia service is bringing everything together. We've got various different referral routes that we've got at the hospital. You can refer in through haematology, you can refer in through the 2-week wait service, you can refer directly to gastro. But we're wanting to redefine all these services, streamline them so that we can bring them all together and treat the patients early so that they're not getting like the later symptoms of iron deficiency anemia, which require inpatient spells. So to do that, this is why we've introduced Stacey's role to bring everything together. Obviously, at the minute, it's under the remit of the consultants, but as we expand that service and bring in like direct choose and book referrals from GPs, it'll sort of like grow and blossom from there, and then sort of like as we go down the cycle, hopefully reducing those non-elective spells.
So patients are seen by me in clinic, I assess them and organise investigations as needed, so gastroscopy, colonoscopy, plus or minus D2 biopsies. If they're normal, the gastroscopy and colonoscopy, we do a pelvic ultrasound scan and prescribe 3 months of iron. And then want to follow patients up, recheck the bloods, give the results and investigations that have been done. If they're still iron deficient anemic, we then follow them up with a small bowel video capsule endoscopy. And bloods are rechecked then again at 6, 9 and 12 months if all these investigations are normal. So benefits of having an iron deficiency anemia service: it's a saving to the local trust and the CCG. Partnership working with the CCG to proactively treat patients and prevent hospital admissions. A dedicated specialist nurse for follow-up and new patients. Centralised referrals with coordinated management pathways. Videos first, yeah.
Alright then. Do you want to show the videos first?
Oh, I'll show them at end.
Yeah.
So I'm moving on and doing small bowel capsule endoscopy. So definition of small bowel capsule endoscopy is a procedure that uses a tiny wireless camera to take pictures of the digestive tract. This is the equipment that we use. Patients are connected to a belt that has sensory arrays in, and data recorder that collects all the videos and images that are downloaded on a computer, and we watch the videos at a later date when they're downloaded. This is the capsule endoscopy, what patients have to swallow. It is quite a large tablet, size of a large vitamin tablet. This is the data recorder where images are downloaded onto, and we're able to real time it and see where the capsule is. So when patients come to me on a morning, before they leave me, I real time it to make sure that the capsule is actually in the small bowel, to ensure that we're getting a complete test, and when they come back at the end of the day, we'll look at it again and make sure that it's in the colon. So why do small bowel capsule endoscopy? Find the cause of obscure gastroenterological bleeding after normal gastroscopy and colonoscopy. Diagnose, assess inflammatory bowel disease, unexplained iron deficiency anemia, celiac disease, and we can screen for polyps as well. Benefits to patient: it's easy to swallow, even though it is quite large, it is easy to swallow. It's a non-invasive test, it's painless, and there's no potential harm from radiation, and often additional investigations can be avoided, and it's gold standard for visualising the small bowel. Capsule endoscopy is a safe procedure that it does carry a few risks, the main one being retention. In routine patients, that's a less than 1% chance. When we're suspecting IBD, it's 1 to 4%, and non-Crohn's patient, it's 10%.
Stacey, what happens to the camera? What happens to that thing at the end of the tablet?
Oh, it's passed out when they open the bowels. Yeah, it's flushed, yeah.
Flush down the toilet.
We just
Flush it down the toilet.
We don't need it.
Factors, we have to have partial non-steroidals and previous bowel surgery. And we screen these patients with a patency capsule, and we do provide this service at Barnsley. What is a patency capsule? It's the same shape and has the same dimensions as the real capsule endoscopy. It dissolves after 30 hours, and it's detected by radiography. If it's still detected, we do a scalp CT just to check that it's in the large or small bowel before we proceed to give capsule endoscopy. So I choose Barnsley for capsule endoscopy. We've got a dedicated capsule team with over 10 years experience in capsule endoscopy. We've got really short waiting times, and we're able to turn reports around really quickly as well. Journey so far: capsule endoscopy service started in 2005 at Barnsley. Service was reviewed in 2014. We've had improved patient satisfaction surveys. Quality of his reports have improved. I was appointed in 2015, and we've managed to shorten turnaround time for capsules reports since I've been appointed, and we've also increased capacity. As you can see from when we started in 2005 now, and all that we're doing. How to access the service? I can refer for capsule endoscopy from iron deficiency anemia clinics or other clinics. We've got a capsule, an endoscopy coordinator, or you can contact myself or Dr. Kapoor to refer into this service. The future: to develop this existing service and expand. We've recently introduced a new colon capsule, which looks at the large bowel, it's offered to patients that were wanting to look at the large bowel but they refused colonoscopy, and we're also wanting to introduce it to look at inflammatory bowel patients that are on biologics to look at whether they're yeah. Thank you. We've just got some videos to show.
I've got a brilliant idea. You know how you were talking about saving money?
Yeah.
Well, why can't we retrieve those capsules?
Your next one will be half price.
Well, I think the difficulty with that is that who will be prepared to swallow a capsule which has come out of somebody else?
I think we let
I've got an interesting story to tell you about that.
These are real, this is the capsule image that is created after the data is fed into a computer. And you can see with a moving video image as it goes along the capsule, the bowel, and tells us what's going on.
move to the next one. I thought that was
So you see
beautiful.
that image that just passed there was a stricture,
Yeah.
so the white banding, so you can see where the small bowels become narrow as a result. So the images do flash by pretty quickly, so you've got to concentrate really hard when you're doing a small bowel capsule video. It can be about 3 hours long sometimes, so you've got to be concentrating all the time, because the images can pass by really quickly.
This is small bowel, this is the biggest one.
All has to be manual. You don't have software.
The software, what it tends to do is the data that is collected, it tends to convert that into a video image. But the reading of that has got to be all done manually. And it can take
You
up.
want to highlight areas of abnormality.
Yes.
where you think that-
No, it won't.
This is small bowel disease. You can feel stricturing, ulceration.
Next one.
You can see how abnormal it looks in comparison to the one that you saw before, where the mucosa looked normal and relatively red, but here it is all inflamed, so strictured.
Do you know with the third one, I think we'll show it and we'll see whether the audience recognises what it is. Shall we?
Okay.
Empty bowel to use it. Empty bowel.
Yes, we need bowel prep. We need to have a laxative in advance.
Anyone?
There's a clue there. 1 second. Okay, you've already seen one bit of the clue there. Another one. Red spot. Stacey will tell you.
This patient were referred with iron deficiency anemia and they were found to have angiodysplasias in the small bowel. That's where the blood's coming from. Fresh blood that you can see.
You won't see that on a small bowel meal, which is why the capsule is really now the gold standard for visualizing the mucosa. Just taking you back to the quiz that you had, where you measured 6 to 7 meters of the small bowel. Essentially, that's what Stacey is doing by doing the capsule endoscopy, visualizing the mucosa of this length of small bowel.
What percentage of the small bowel condition is responsible for the iron deficiency anemia?
The small bowel, the main things tend to be angiodysplasias. There tend to be sometimes polyps, and of course we do see inflammatory bowel disease and cancers, non-steroidal anti-inflammatory drugs. So a reasonable amount.
What percentage out of 100% of the iron deficiency anemia, what percentage of the condition from the small bowel?
Small bowel.
Responsible?
I'd say about 20-30%.
Which is what doing.
It is definitely.